getting back on the track. So I'm very happy to, right, because they're still coming on. It's so great. I'm admitting the last few people. All right, welcome to Casual Conversations. Happy October. Our last show was in July, and we took a hiatus for August, September, and we're really happy to have you back again with us today. We have shows planned up until about December 20th, and then we'll be back again in January. Today, I'm really excited because it's the first time we've had somebody on the show with a background in not only the lived experience, but also now a practicing expert in the topic of vision. And vision comes up a lot in our support groups and a lot online. So welcome to Casual Conversations. This is hosted by IBIA and NABIS, when we're always grateful for their help, and Colleen and Jennifer and Megan that help us in the back of the as our tech people. So I'd like to welcome Dr. Theis to the show. How are you doing today?
I'm good. How are you doing?
I'm great. So I'm going to just change the view here. It's always exciting to ask practitioners how they became interested in the field. It's not a field where anyone makes millions or gets invitations to red carpet events in Hollywood, but those that are in it are really dedicated. So what was your pathway to being interested in brain injury?
Yeah, so for me, it was very personal. I was a competitive athlete my whole life, mostly soccer and snowboarding. And in high school, I got my 8th concussion. And I don't know, when you've had 8, shocker, everything's kind of a blur. I don't know when exactly my vision went down in my head injury, but around number 6 was when I started getting headaches and things with reading. And I saw pretty much every practitioner known to mankind, and they always kind of told me my eyes are normal. And, I was an athlete, so I had 20/10 vision, the eyes worked really well, but every time I'd try to read a book, I would fall asleep or I would get a massive migraine.
And how old were you when you had your first concussion?
My first one, I was 12. And it was a doozy. It was one of those, I went up to head a ball into a goal, and goalies are taught to punch out. So they punched my head instead of punching the ball. And then the other side of my head actually hit the goalpost. So lost consciousness, woke up. Dad very nicely told me I scored on the play. So that was nice. But back then we didn't have the protocols we have now for return to play. So pretty much I said I was fine and kind of shook it off and kept playing. And then after that, I just got concussions really easily. So, and I think we know a lot more about that now, but back then, pretty much if your neuroimaging was normal, you were fine. You could keep playing.
And when did you start to notice vision issues?
So vision issues are vague, and we'll kind of get into that a little bit today, but my issues with inattention and trouble with reading for long periods of time, I think that started maybe my sophomore and junior year of high school. And then it persisted. So it persisted all the way through college. So I ended up being a biochemistry major in college. I always knew I wanted to go into some sort of medicine, but didn't know which one. And I randomly decided I'm just going to follow a practitioner every single week in a different branch of medicine and see what kind I want to be. And I happened upon an optometrist. It was actually the first time I'd ever seen an optometrist in my life, because when you have 20/10 vision, no one tells you to go see an optometrist, because they only do glasses and contacts is kind of the misnomer. But they did a couple of tests on me just to kind of show me what an eye exam was like with an optometrist. And the doctor said, "Can you read?"
You were in the chair as just the guinea pig.
The demo patient. They were like, "Yeah, I'll show you what an eye exam is like," because we were just waiting for patients to come at that point. And she looked at me just in the face and just said, like, "Can you read?" And I laughed. I was like, "Not really." And she goes, "I can't imagine that you could, not with the way your eyes are aligned." And it was the first time that anyone had looked at it, had tested it. And then she had told me kind of candidly, we don't do vision therapy and we don't do anything for brain injury, but there are optometrists out there that do, and they can fix this for you. And it was the first time, I think, for me that someone found something wrong that could be fixed. And it was such a rush of relief. And then, so I went to an optometrist that did vision therapy. I'm from Colorado originally, so flew back home for summer vacation. And then they offered me vision therapy or prism, and I couldn't do vision therapy at the time. So I just used prism, which helped. It allowed me to go from reading from 5 minutes to about an hour before getting symptoms, which still isn't perfect, but when you're in college, it's huge. And then I ended up doing vision therapy and kind of finishing it both within the rest of college and then kind of intermittently during breaks because I just couldn't balance it all. And then I did a lot of it during optometry school. So kind of fixed it finally.
And at that point, had you been seeing a doctor for glasses and contacts?
So I never needed really glasses or contacts. I just needed those prism. And up to that point, because I had great vision and normal eyes, nobody had said that I had an eye problem at all. And they all thought it was just like regular headaches. And their big thing that they always said was, just wait it out, it'll get better. And it took me 6 years to get appropriately diagnosed. And then the glasses fixed it instantly. So I was a little angry initially that it took so long to be referred, and it wasn't even a referral, right? It was just happen chance that I happened to be in that doctor's office and they happened to do that exam.
Now, are the glasses that you had, the prism glasses, were they actual prism glasses or the ones where they put the black duct tape on the corners, which I've seen?
Yeah, so that's the binasal occlusion. So they were the actual prism glasses. So the condition I had was convergence insufficiency. My eyes just couldn't cross enough to see up close for long periods of time. And so what prism does is it just moves the images outwards, so the demand on your eye crossing is lower.
So that's when the directional is too close. So the prism takes the image and moves it out further. So you're still holding it at a normal length, but your eyes are able to cross further out.
Yeah, so it essentially allows your eyes to be in there more of a resting position and not have so much demand. And studies have shown that prism glasses don't actually fix in the sense of cure the convergence problem, but symptomatically it definitely increased my reading stamina, which at that point in my life was what I really needed because I was in college.
So I've heard of the criticism of prism glasses being it's a crutch, but at that point, you're walking out, or technically you're walking around on a broken ankle. So a crutch was great for the situation you were in at that point.
Exactly. So I've had that from a lot of colleagues where they, I don't do prism because it's a crutch. And I'm a big fan of meeting patients where they are in their life. We can't all ideally take time off to do rehab right in the moment that we get diagnosed with something. And so if you can give me a crutch to get along long enough until I can have the time and the resources to be able to do the thing that will cure it, I think there's nothing wrong with a crutch.
Now, are there different kinds of prism glasses that one would get a certain strength of a prism glass? Or is it, so if somebody wanted to try that idea?
So you'd have to see someone that specializes in it because prism is an art. And there are many different types of prism for many different types of conditions as well. So a term out there is yoked prism. We use that a lot in stroke patients to move things left or right versus moving outwards and inwards. And it all depends on where your eyes are aligned, both developmentally and whatever happened after your head injury. And so they have to take all of that into account. And some people, everyone's different. So even if my eye turns as big as someone else's, my ability to tolerate prism will be different than someone else's. So everyone, it's very specific on how much prism you can tolerate at one time.
And if you go to a regular eye store at a mall that does glasses and contacts, will the medical providers there be able to do this, or is it an optometrist that one needs to do?
Usually depends on the state, but it should be an optometrist that is in a lot of those stores, and a lot of them were trained how to do it. And if I will say, I think I get more referrals from those types of opticals, because what's wonderful about those optometrists in primary care is that they will at least do the screening. Like the doctor that I saw when I was in college, they didn't treat it or do the prism, but they screened it to know the problem and then referred me to someone that's good at doing the treatment.
Okay, so then let's take a little more about your career. So you have decided that this is the field that you're interested in.
Yeah, so immediately after I all of a sudden was able to read and all my headaches went away as well, I was first of all, just angry that I'd had symptoms so long that could have been fixed. And I channeled that anger and decided, I'm going to do this for a living. I'm only going to do people who have vision problems and brain injury. That's all I want to do. And then I started looking at optometry schools and ended up settling on Berkeley. So flew to at the time I was in Pennsylvania, so I went to California for grad school. So optometry school is 4 years. And I think it's funny when I look back on it, because all of my professors at some point said, what do you want to do? And most people will say, I want to do ocular disease, or I want to work in a hospital. And I always adamantly said, I want to do sports vision, and I want to work in vision problems and brain injury. And a lot of them told me the niche was too small. They were like, well, that'll be a cute part-time hobby, but there's not that many patients with that many problems. You'll probably need to do something else on the side. And secretly, what I realized was it's a small niche because people don't know they should be referred. And so it's actually a huge patient population that needs treatment, and people just aren't aware that they have vision problems because it's not the typical blurred vision, double vision complaint. So then I did a residency in neuro-optometry and brain injury at Berkeley as well. And then after that, I stayed on as faculty at Berkeley and actually started the first sports vision and concussion clinic in any of the optometry schools across the country, which was located in the football stadium. And I did clinical care and clinical research in eye movement problems in head injury.
That is just so amazing. And my own son, so I was just saying, well, we're going to, people already have questions. We'll be going to questions at about 3:40. My own son, his reading was the first thing that was affected with his concussion. And this was in 2008. And we were just told he needs to rest more. And he seemed fine. He was walking around. It was the reading that was keeping him from studying. But the protocol at the time was to stay home. So on top of that, there was the social isolation. And now after COVID, everyone understands why it's better to be in school than to be at home. So again, the same thing is that now looking back, I think it was his eyes, and that wasn't anything that was being looked at, even though he'd seen about 4 or 5 doctors at the time. When did eyes start to become a component of the workup for someone who has persistent symptoms?
I think eyes kind of nationally or even globally started getting recognition only recently in the last decade. So I think you and I have talked about it, but a lot of the work that came out of the Pittsburgh group, looking at the vestibular ocular motor system and working at actively treating a concussion instead of passively letting people rest and try to recover, is the first time that the ocular motor system really started making a good front in the research. And anytime something happens in research, it takes about 10 years to actually transition into bedside manner. So even though we know that the eyes are incredibly commonly impacted in concussion and head injury, about 50 to 80% of people will have some sort of visual or vestibular dysfunction, there are still going to be doctors today that don't screen it and don't look for it and don't know it. And it's not bad on the doctor so much as research is just happening at an exponential rate, and it's going to take some time to translate that over into the clinical side.
And I think that's what's the frustrating part of it, is the 10 to 15 year lag. And with everything else so quickly, everything else happens at such a fast pace. There's this frustration is, why doesn't my doctor know this? Well, it is still a 10 to 15 year lag. So that's, I think, where patients' advocacy is so important, that if you can take a peer-reviewed journal article to your doctor or suggest. And the reference to Mickey Collins' work on VOMS, VOMS, and shorthand, or people call it the vomit test. Do you want to, and I remember, and I was trying to think, it was 2014 or 2015 at the Harvard Concussion Conference, where Mickey got up, Dr. Collins got up and presented what VOMS would be. Do you want to, could you give the professional view of VOMS?
Sure. So I love VOMS because I think it's a wonderful screener that anyone can use to be able to screen the system. I don't think it's accurately diagnostic necessarily, and I can go into that in a second. There's a great paper that came out of Boston Children's about a year ago looking at that, but essentially what it is it is a resource where you baseline someone's symptoms. So mostly we're looking at headache, dizziness, nausea, and brain fog or floatiness. And then you do an eye movement test. Maybe you have them look quickly side to side and up and down. And then you see if their headache, dizziness, nausea, brain fog got worse. And then you kind of give it a point value. And you do this for about 5 different assessments, and then they get a score. And so then there's been a number of studies in the last 5 years looking at what the score means, in the sense of, we know that people who have symptoms when tested on vestibular ocular motor screening are more likely to have had a head injury than not. So it's helpful in differentiating, do we think this is a concussion or not really? So people who have never had a concussion and don't have a history of some kind of pre-existing ear or eye problem, they're not going to have symptoms provoked by this test. And so if you do it and it provokes symptoms, you're more likely to think, yeah, they are more likely to have had a head injury. My issue with the test as an eye care provider is that it's a subjective test. So you're still, and we have so many subjective tests out there of asking how patients feel. And there's so many issues with subjectivity in concussion, because there's motives at play. So you'll have the athlete like myself as a kid who thinks they're smarter than everyone else and will just lie. How do you feel? I feel fine. I always say fine means feelings I'm not expressing. So I feel fine. And then you'll have the person who maybe actually is fine, but says that they're not fine. And that makes diagnosing a concussion very difficult on the practitioner. And the beautiful thing about eye movements is the ocular motor system is objective. So I can see how the eyes are moving and it looks abnormal. Whether they tell me how they feel or not, I can tell by looking at the eye movement if I think it looks like something that's more head injury related or developmentally kind of a problem for them. What I had referenced to earlier was there has been some recent studies looking at the near point of convergence, because convergence insufficiency is a really hot topic in our area right now. And what they found actually is that of people who had reduced convergence, the majority of them actually had accommodative or focusing disorders and not actually true convergence insufficiency. So in optometry, we call that a pseudo CI. So it looks like a convergence problem, but it's not. It's actually a different eye movement that's causing the main problem. And the reason that's important is because for patients who maybe have done vestibular PT and they worked on their convergence, but they still have these issues and they never saw a neuro-optometrist, it behooves them to try, because sometimes it was just not rehabbed appropriately, because there are other eye movements that are not screened in VOMs and are not rehabbed at vestibular PT that a vision therapy oriented clinic can help patients with.
Well, there's 3 directions I want to go right now. Okay. So somebody goes away from this and says, oh, I just heard something about eye tests. Here's where I get them, and eye therapy. There's a lot of criticism. Oh, eye therapy doesn't work, which comes from the past. What do you say to people who say, eye therapy doesn't work?
I hear it all the time. So the first question that I had, and I think a lot of this stems from, there's a very large gap within the literature on vision therapy. So we can start there, and there's different types of vision therapy. So there's developmental vision therapy, there's neurorehabilitation vision therapy, ocular motor vision therapy. So I think one problem is there's this overarching term vision therapy, and I don't know necessarily which type they're talking about, because there is definitely clinical evidence and research trials on vision therapy being effective, and actually the only effective treatment in convergence insufficiency. There is not as much evidence that vision therapy can help with, let's say, learning related disorders. And I always, there's a paucity of literature in general in treatment options and therapy. But if you look at, and that's really in PT, OT, and in optometry. And I think part of that's, especially in head injury, as someone who did research clinically, it is so hard to do clinical research on a head injury population, because every head injury is different. And even if one person had multiple head injuries, each of those head injuries will be different for that person. And so it's really hard to kind of make a lot of really great assessments on a group of patients where they're just so different.
It's hard to line everybody up. It's like you're trying to line up a stack of cards and every card is different. So it's hard to get this alignment to then actually get the research done. So if you are on this call and you take away from this to try to get an assessment and get some eye therapy, just know you will encounter people who will say, oh, eye therapy doesn't work. So just say, yeah, I've heard that, and then move on. Okay, so now I'd like to talk about tell everybody what tools a doctor needs to do the VOMS test,
Well,
besides a medical education.
I think there was a study that said you didn't have to. There was actually a standardized study that says you don't need a medical education to do this test. But essentially you need, I don't do it. I teach it to people to do it because it's a screener, I think, for not eye care providers to be able to learn when to refer to an eye care provider or a vestibular PT. But essentially you can use your fingers or you can use a small target. But really it's minimal equipment and in the sense of, technically, yes, there's a standardized protocol that had to be done in order to get it published and standardized, but you can use the assessor can really just use their 2 fingers, having you look side to side, up and down, and having you do movement and body movement and head movement and be able to tell if the person has symptoms or not. It's not as accurate. So doing a near point of convergence with a finger, you're going to miss a lot of, you're not going to be as accurate than if you use an actual small and appropriately sized target, but it's great in the sense that you don't really need equipment to do it.
So then the idea was, so if it's a human doing the actions in front of another human, counting, the idea was, how can we go to the next step and make a machine that does this? So there are a couple of different machines in the pipeline, and one study that you and I were talking about that uses virtual reality goggles as a test.
Yeah. So, and I think that I like the idea of goggles in the sense of, we have some great technology right now that can actually track the eyes and actually objectively say there are XXX percentage of abnormalities in this eye movement. So it adds some objectivity to the test. One of the problems, though, is it matters how you do the assessment. So the software or the way that they decide the eye movement pattern is going to go. In my experience, one of the problems is that you're provoking nausea already or provoking dizziness already with the VOMS, hence why it's called the vomit test. And you're doing it on purpose, because if your eye movements are provoking symptoms, that's what we want to know. But sometimes just wearing those goggles for someone who hasn't had a head injury can make them feel dizzy and nauseous. So that can be a little bit of an issue. And then the other issue that I have sometimes when we look at using that on a sideline is we don't yet know the timeline for the onset of eye problems and concussion. So we did a study at Berkeley where I would see a patient after they had a head injury in a sport game, 24 hours, 72 hours, and 1 week after injury. And a lot of patients got worse over the 72 hours from their injury. So you might have someone where on the sideline, maybe you did VOMS testing and it was fine, but then maybe 24 hours later, it wasn't. And so I think it's sometimes hard when they say it's not a great sideline screener. And the question is, are sideline screeners great anyways? Because we know that concussion develops and the neuroinflammation develops over time.
And let's put a pin in that one. I want to go back to the timeline. There are other eye instruments out there that are being tested where someone puts their chin in a kind of a brace. There's space, and then there's a screen, and there's diagnostic tools within the computer looking back into the eye, as opposed to putting a goggles on.
Right. And the beauty of those is a couple of things. So number one is it will isolate the neck and head movement. So head movement is going to impact eye movement. And same with, there's a vestibular. So vestibular is your inner ear. So the vestibular ocular motor system are tied to each other. The ears and the eyes are constantly talking to let us know where our head is. But the neck also has correlation to the eye movements. So if somebody has a whiplash injury or unstable neck, to support their eyes while they're moving, then they can have abnormal eye movements. So the beauty of those stands is you take some of that vestibular head and cervical neck movement out of the eye movement assessment. Now, the problem on the other side of that is those machines are generally ginormous, and it makes it almost impossible to do a sideline screener with those types of kind of technologies.
So let's talk about, so there's a variety of different things coming down the pipe, and I know everybody's racing to get FDA approval, and there's cost when you have software to buy, there's cost when you have hardware to buy, and it gets it further away, barriers of access come up. So those are sort of the tools out there to look for and stay in connection to the research and what's being approved. Now let's just talk about this length of time. And I know people want to ask questions. So there's the initial injury, and then there's the when you get to the first level of help. So let's say it's a sporting event or it's a fall, there may be a couple of minutes till you get to help. And then there's, you know, a 24-hour assessment period where maybe you've now gone and seen a doctor at an appointment. Then there's a couple of weeks, and then you get out to 4 weeks and beyond, where you're now, instead of an acute injury, you're now in the former word post-concussion syndrome, that we're putting that in a box, throwing it very far away, and we're doing prolonged or persistent concussion symptoms. So you're 4 weeks out. Do the eyes change from the moment of injury through that time continuum that we know the chemical cascade is going on? We know the biomarkers are changing. Do the eyes change during that period, or do we not know yet?
They do. And we actually were learning more and more. So what's interesting about the eyes, in my experience, when I did do sideline testing, is I found a lot more ocular motor dysfunction in 24 to 72 hours after injury than at the time of injury. And then usually those around 72 hours, in my experience, was the peak. But again, we don't have any data points for days 6, 7, 8, 9, because we, you know, had to let the kids also go home and do the rest of their lives and not be in my lab the whole time. But we do know that the first 72 hours it gets worse and then it stabilizes. What's interesting, we did an observational study initially before the team paper came out of Pittsburgh saying you could treat them actively. And so when we just passively let them rest and see what would happen to the eye movements, and a lot of other studies have validated essentially the same results that we got. We know that balance tends to get better quickly on its own. It's usually impacted. It's great for diagnostics on the sideline, but it gets better pretty quickly, usually within about a week. We know that a lot of symptom score tests like the SCAD are going to get better in the next 2 weeks. And then the cognitive complaints usually get better in 3 weeks. And for whatever reason, on a lot of the observational studies, we found that a lot of people do recover, but they take about 4 weeks on their own in their first head injury without any other kind of barriers to recovery. They're going to get better in about 4 weeks. So that's one of the reasons I think it's really important that primary care physicians and pediatricians do the VOMs initially, because if you see that there's an ocular motor problem initially, you can essentially know that that concussion is probably going to last longer than 7 to 10 days. And I think that's really helpful for patient care, because patients get really worried when they're around week 2, 3, 4 and not feeling better. And so telling someone like, hey, your eyes are involved, that suggests this might take a little bit longer to resolve. So we're going to watch you closely. But if this lasts 3, 4 weeks, that's not atypical. And letting people know that that's normal. So studies have looked at, you know, how many people get vision problems after a concussion, and the studies are all over the map, but they essentially say about 50 to 80% of people are going to have some sort of eye movement problem after a concussion. And of that 80%, about 80% will completely self-resolve without vision therapy in 4 weeks. So you don't need to intervene on everyone all the time. However, there's that 20 to 30% of people with the persistent symptoms beyond 4 weeks. And those patients, if they don't get vision rehabilitation or vestibular PT, they do not get better.
Do we have sex differences? Any breakdown, male, female, adolescent, adult for those stats that you were quoting?
So I don't think that there's any gender differences statistically looking at ocular motor functions specifically, but I also think that the research is only just coming out, so we don't know what we don't yet know. Clinically, we know that a lot of ocular motor dysfunction happens with whiplash type injury, and we know that women are more likely to have some sort of cervical kind of whiplash injury with head injury. So it wouldn't surprise me if we found it more in, you know, women or men. But again, the other thing that can be a confounding risk factor is that ocular motor dysfunction is not necessarily uncommon developmentally. So the estimates about 10 to up to 20% of the general population will have eye movement problems just from not developing appropriately. And that can also kind of mug up some of the literature and the findings as well.
Is there any research yet that having a lazy eye or having some issue before a concussion would make one more vulnerable post-concussion? The same way that if you're motion sickness, and if you have motion sickness in a car or on a boat, that they're more likely to have that particular symptom after a concussion?
So it's a great question. Candidly, I can tell you not necessarily. So when we did our study at Berkeley, that's the question we were trying to answer. And so we baselined everyone and we saw, yeah, people have ocular motor dysfunction that they were not symptomatic for. And then when they got a concussion, they got completely different ocular motor problems that they were symptomatic for. So when we did the rehab, we rehabbed them back to whatever their normal was. Sometimes if you don't have a baseline, it's hard to tell. And that's the hard part, in which case then you have to kind of say, I don't have a baseline for you. If we're going to be doing something like return to play, we just have to get you back to norms, in which case it will take longer to rehab that person, because you're also going to have to rehab not just the head injury eye movement problem, but the developmental eye movement problem as well.
And to take it into another area, ADHD, they just did a giant meta-analysis and were able to show that a mild TBI as opposed to a severe or even a moderate one, that they didn't show that a mild TBI caused ADHD, but what that they found is that it was a time to screen for ADHD. So they were screening and finding people that hadn't been picked up as ADHD before. So this, if one has never had an assessment of the eyes, it could be from the mild TBI that you've had, or it could be something that hasn't been picked up before.
Yeah, and unfortunately, a lot of the ocular motor testing, if someone doesn't complain about it, and kids particularly don't know that they're supposed to complain about something because everything to them is their normal, they're not going to get screened for it. A lot of these tests that I do are not tests that are done in a regular kind of primary eye care setting. It's definitely ancillary testing that you have to do. And so they might have seen doctors forever for their eyes, for glasses or contacts, and never had it screened. So even then you can't say that they necessarily never had something pre-existing.
Is that an issue with the providers for glasses and eye care, that they should be doing all these screenings for everyone, or is that just cost prohibitive, time prohibitive?
I think it's not cost prohibitive. I think it's time prohibitive. I think we all know with healthcare that the time with doctor is shorter and shorter and shorter. And so I think emphasis in primary care is more towards eye health and glasses prescription, which is usually what they're there for. I always, and I kind of, when I lecture a lot of optometrists for CE, and I always say, it's really important to do it once, just once do you have to do an ocular motor screening on a kid. And if it's normal, you're good. It's never going to randomly be abnormal. So if you meet someone for the first time, it behooves you to add 5 to 10 minutes to their new patient exam to do this, particularly for a kid, because it can be a barrier for learning. And right now, especially with Zoom learning, where it's something, because a lot of these problems are only going to be issues from, let's say, 50 centimeters and closer. So maybe they don't get picked up in class because they can just kind of look at the classroom board, but they'll get picked up now. We had a lot of new diagnoses with the pandemic just because everyone's stuck on a computer now.
Right. And so I do think it's important. Like I went through chemotherapy when I was 47, 48, and I went into the eye doctor and I said, oh, I can't read anything. The chemotherapy affected my eyes. And she said, you're almost 50, you're old. You just need glasses. So it's not necessary. It's important to say, if you go out for this screening, to understand that this may have been an issue before, or it may have been an issue from the TBI if it's sort of a chronic situation, but important to check that out. So how would somebody know what kind of symptoms would someone be having? Oh, actually, no, I know there's so many questions. All right, I'm going to switch to this question. In the future, if you were, you king of the world, what would you like to see? How would you like to see this particular skill set that you have applied to the brain injury field? When, where, how, why? What would it look like for you?
Sure. So I think one of my overarching goals has always been to reduce the time gap for referral between optometry and the managing physician of the head injury, whether it's neurologist, PMNR, primary care physician, pediatrician. So in general, most people don't get referred to an optometrist. A lot of people don't know that neuro-optometrist is even a field or exists. Part of that is on us. There's not a lot of us. When I went to residency, there were 4 residencies in the country for it. I think now there's a whopping 10. And a lot of those extra 6 that we added are in the VA. And a lot of people, when they go into the VA for this residency, they stay in the VA, and which is great. It's a wonderful career path. And there's a lot of brain injury in the VA, but we need more providers in general. I'll start there. So we need people to actually go into the field. We need to increase communication between providers to let people know that we can treat concussion. And that's a huge thing for me, is that you can treat it and get people better faster and back to the things they enjoy. You can't treat necessarily everything, but the eyes are really treatable, and that's the beauty about them. And then my other big overarching thing is understanding that the referral isn't just blurred and double vision. And that goes on to a little bit, I think, what you're going to just about ask, which is what are the symptoms? So in head injury, the symptoms aren't necessarily, some people will flat out have blurry vision and double vision. And those ones will always, or light sensitivity, they're always going to end up in an eye doctor. The ones that are going to go unnoticed are going to be the more subtle ones. So it'll be something like, I get really dizzy when I scroll on a computer, or I just, I can't look at Facebook anymore, or I can't, it's a lot of things where we have a lot of visually crowded things in our space. So for instance, going to the grocery store, when we have vestibular ocular reflex disorders, we can have trouble with patterns. We can have trouble with feeling dizzy and imbalanced on patterned floors. We can have trouble going to the grocery store. We feel like we're having a small panic attack. And it's really just the visual system's way of saying, hey, there's something wrong with my visual system. And so we need to be on high alert. And whenever the visual system's on high alert, it's paying attention to everything. And then if you're paying attention to everything, you can't pay attention to anything, which is a weird thing to say. So, I looked in the fridge for the milk and couldn't find it, but it was right in front of me. We call it a visual processing dysfunction, but sometimes it's actually just an ocular motor dysfunction. And the brain is beautiful in the way that it is built, because the eye movements actually span every single lobe of the brain. So just to mechanically get them to move left and right and up and down. But the information that it leads to the brain then also gets processed multiple times in the lobes as to let the person know where they are in space and how they interact with the world. And so sometimes we have visual processing issues, or how we interpret visual information, and it's not an eyeball problem. It's kind of an eye brain problem. And I think it's letting people know that these number one, the symptoms are real. The grocery store always cracks me up, because I ask that all the time and people look at me like, how did you know?
Right.
And it's common, and letting people know who to refer to. I think that's the hard part of, oh, this is a weird symptom. Oh, it actually should go to an eye doctor, even though it's not blurry vision.
It's that when you walk into Costco and you literally just want to throw up, like you don't even know which way to go. Yes. All right. So there's 6, speaking of not knowing where to go, there's 18 comments that I haven't read in the field and in the chat line. Is there anything else before we go to the audience questions? Is there anything else that you would like to put out there into the world?
Not yet. Let's tackle the questions and maybe something.
Okay, so let's go to the chat. Well, first we'll just read a couple of chat questions, and then we'll go to Dr. Adhd Harris. Hi, big shout out to Odette Harris and the Stanford Palo Alto VA. See if you have a question. We're doing questions, wondering. There's barriers in Canada, some Ontario people. Can you comment on the computer program for eye therapy called Right Eye? Is this a helpful program or not?
So the Right Eye, so I know the company well. We have one in our office. So the Right Eye is nice because it can quantify some of the eye movements. It's a pupil tracker for those of you that don't know. So when as I had mentioned, when we move our eyes side to side, it will track the eyes and let us know just how anomalous it is. I personally have found that one of the problems in my patient base is, because I see mostly severe at this point, by the time they come see me, it's pretty severe. They can't tolerate computers. So a lot of people are like, oh, is there a computer program for vision therapy? And most of my patients can't tolerate being on the computer. Part of it is because the wavelengths that computers emit are short wavelengths, which trigger migraine, in which case it's not helpful to do things on the computer. I also have found that some of the exercises, you have to be very particular about the exercises that you prescribe to someone. You can't just blanket say like, oh, try this program and see if you get better. It has to be, this eye movement is the problem, and here's level 1, and we kind of progress people through the levels of it until they can get the eye movement better. So it has to be very tailored to the individual. So anytime I see these programs, and I'm not mad at the right eye at all, because the right eye is not touted. It gives you tools, and it's how you use that tool for your advantage. And that's what I love about it as a provider, is I can use it however I want to use it. But I always caution people to be careful if there's ever one kind of blanket statement about like, oh, this will fix it and it's automated. Everyone's different. So if it's automated, it has to somehow be individualized, and that can be a little tricky.
It's like going to a gym. There's a lot of equipment there. You just have to know what's right for you, how to use it, and have the right weights on it.
Exactly.
Some real quick question. How would a sella fraction impact eye function?
The sella fracture, I mean, it depends. Anytime you have some sort of fracture that's near the orbits or the muscles, it really depends on if a muscle is trapped or if a nerve is trapped, in which case then it can make it hard for the eyes to move efficiently. But a lot of times we can have fractures in the bones and the fractures heal and they do just fine. So for instance, a blowout fracture where someone actually, the entire orbit gets broken or blown out, as long as the muscles aren't trapped in any of those bone fragments, people from an ocular motor perspective usually can recover just fine.
Here's a question about processing speed, and I'm trying to do sort of more general questions. This was an issue with my son. Is processing speed slower after a TBI? Is that usually more of an eye tracking issue or more of a cognitive issue? And how can one improve one's speed?
Sure. So it could be either, and it depends on the person. So when I do a test in our office called the developmental eye movement test, and the beauty of it is it's a number naming test, but it isolates visual processing speed from tracking. And so essentially you baseline people by having them read a certain number and series of numbers out loud. And there are age norms. So we can tell just compared to age, are you slower than the average person your age reading this test? So that's helpful. And then it does a second battery of tests that has the exact same number of numbers, but in a very sporadic order that increases the amount of eye tracking. And so if they are slower on that second part than they are in the first part, that indicates that their processing speed is slowed by their eye movements. If, however, that second subtest is the same as the first subtest, that indicates that it's more cognitive, that they're having trouble with visual processing speed. As far as visual processing speed goes, there's no study candidly saying that you can do anything to make it better. That doesn't mean that there's nothing that you can do to make it better, but there's no study that it absolutely tells you what to do. I do know that for patients, if it's caused by ocular motor dysfunction, the second that their ocular motor dysfunction or saccade, which is your fast eye movements, when they get better, your visual processing speed gets better right away. So some people, though, they might have sleep problems, which we don't talk about enough. Sleep can impact vision, sleep can impact cognition, and sleep will definitely impact your visual processing speed, whether you've had a brain injury or not. And since sleep is such a problem in head injury, I think that's another thing that we need to make sure, kind of full circle, that people are getting.
Yeah, no, and the endocrine dysfunction, it affects the sleep, the eyes. I mean, it really is. The brain is absolutely incredible when you start to think of all these systems that are involved. And I know it's overwhelming sometimes for patients to try to find who, what, where, why, and connect all the dots. Is there a point, there are some general questions out here about, is there a point when it's too late? Like my TBI was X number of years ago. Is it a point where it's too late to actually go to be assessed? Or at some point, you've done vision therapy, it's not helping. Is there a point where you just move on?
So great questions. And I love this question actually, because it would be the one thing I would want people to know, which is it's never too late to get assessed. I was assessed 6 years after my last injury, and I ended up doing rehab 6 years later and was fine. I see patients all the time that are 4 weeks out from their injury. I see them up to 10 years from their injury. Now, candidly, does it take longer to get better if you're farther out from your injury? Absolutely. But a lot of people still get better. Maybe not 100%, but 70%, 80% is still way better than zero. So it's always worth trying. As I mentioned earlier, the visual system really overlaps with the cervical and the vestibular system. So for me, if I'm working with someone and they're not getting better 100% in vision therapy, that means it's not 100% an eye movement problem. And we then have to circle back and say, well, Did we do enough orthopedic PT for your neck? Did we do enough vestibular PT for your ears? Are we working? Do we have an endocrine dysfunction? So it's, if your therapy didn't get you 100% better, I wouldn't say give up, but I would say we have to recircle for something else.
Yeah, and I do want to, this is pretty visual imagery. When I was 19, I was told I couldn't have children. And they said, you won't have children because of an endocrine issue. And 10 years later, there were multiple ways in different countries that hadn't come to the United States, but came to the United States, and I have 3 children. So science is a continuum of where, but no one told me after menopause, there were a whole bunch of new sets of symptoms. So there's our lifespan and how we change through time, and science is exponentially changing. So even though the expert of the moment told you XYZ, in TBI, 6 months to a year later, there could be other options. So it's just really, really important not to give up or lock in, and I can't tell you how many baby showers I ran out of crying all of my 20s because I couldn't have children. So I want to make sure people with all patients with brain injury, with that lived experience, that things are changing. So we create an identity about who we are, and this is how it is, and this is how it's going to be. And we have to really stay flexible for the new options that are coming along.
Well, and I think what kills me a little bit is, I don't know who's touting it out there, but someone has this 1 year moniker where they're like, well, if you're 1 year out, that's as good as it's going to get. And it breaks my heart because you have these people where they're like, well, I'm 1 year out, this is my life now. And I think there's something to getting back into your life, but I think it's also really important that we make sure that people know that neuroplasticity is only barely understood right now. And we don't know what we don't know about the brain, but we do know that people do get better after that year mark. And it's just trying to figure out the kind of the sweet sauce as far as what needs to be treated in order to get people to feel better. It also does depend very much so on the level of the injury. Mild versus moderate versus severe TBI matters as far as what you can recover. So for instance, visual field loss, if you got a brain hemorrhage and it physically damaged the optic nerve, that we do know that rarely, I would say if ever, does the vision come back after 12 months. Doesn't mean that the patient can't function, but it's, there's certain things that we know absolutely because of the level of damage. With concussion, the neuroimaging is often normal. It's considered a functional disturbance. So we don't know from a functional standpoint if we can get function back if there's no structural damage.
And so many things. Well, okay, so we'll go to the audience now. And because we have so many people, if you could do a 1-sentence intro, and my question is in that format. We can try to get some live questions. One last question, the blue screen, blue tinted glasses. I know that people hyped that for a while, then I read that was not so. What's your thought on those?
On blue blockers?
Yeah.
Oh, okay. They grind my gears for a couple of reasons. So number one is blue light has a function. It is not inherently evil. So blue light helps regulate your sleep-wake cycle. There's a very specific retinal ganglion cell that turns on when there's blue light around, and it tells your hypothalamus that it's daytime. And then when blue light goes away, technically the sun goes down, then that retinal ganglion cell turns off, which then tells your hypothalamus to start upregulating melatonin. So the problem with blue light is just that we have artificial blue light everywhere. And so with artificial blue light, it can really disrupt sleep-wake cycles. And so we do want blue blockers at night. And usually the best blue blocker is just turning your device off or putting it on night mode, which is actually the best. And then that way you can help with your sleep-wake cycles. So a lot of my brain injury patients, they come in and they have blue blockers on all day. But if you're wearing that blue blocker all day, you're telling your brain that it's nighttime, and that can add to your chronic fatigue. So it can actually make you worse. So we do know that having some blue light exposure in the beginning of the day can actually help with sleep-wake cycles in patients with brain injury. In light sensitivity, we also know that there's something called dark adaptation. So if you deprive the retina of light, it gets more light sensitive. So people who are wearing sunglasses all the time can become more light sensitive. And so we actually want to be able to monitor that and make sure that they're not overdoing it and they're only wearing it when they're outside and they're not kind of shying away from light.
Wow, that's really interesting. Nat Dean, you have your hand up.
Thank you. I'm a survivor of 3 known TBIs, and for about 3 years, I was having a lot of difficulty with feeling like my right and left eye were not working well together. What was interesting is that it just took someone taking extra time with the swing test to identify an RAPD, relative afferent pupillary defect. Once knowing that, there was something I could do to accommodate and understand it. Do you find RAPD coming up for patients very often where it's just not understood, or they don't take the time to see the subtleties of a RAPD in a brain injury survivor? Thank you.
Well, I will say, so for those that don't know, the RAPD test is we're looking for a difference between the pupils when you swing a light between the two. And I will say it is very hard to do in someone that's light sensitive. So sometimes it's hard because people, when you're trying to shine a light in their face, are just blinking nonstop. So it's hard to do. RAPDs can be difficult to ascertain as well. So I agree, it takes time to study it, but sometimes for me, it actually takes getting patients to be less light sensitive before I can even accurately assess it sometimes, because light sensitivity can be so intense.
Thank you.
It gives me a headache thinking about it. Dr. Zimmerman, or Mark Zimmerman.
Thank you. Yeah, I have a really close friend that has a serious TBI, and it's in the midst of evaluation. Can you explain to us why a neuro-optometrist as opposed to a neuro-ophthalmologist is the appropriate specialist to treat problems for visual difficulties with respect to TBI? And we talked a little bit about the delay in diagnosis, but do you think that a person that has a serious TBI should be sent to an optometrist as a matter of course by the primary care doctor?
I think, so 2 great questions. I don't think that neuro-optometry necessarily, I work with a lot of neuro-ophthalmologists, so I guess I'll start there. I don't think we necessarily replace neuro-ophthalmology. I think that we work really well alongside them. So a neuro-ophthalmologist has completely different training. They went to medical school for 4 years, then they did an ophthalmology residency, and then usually another additional neuro type of residency. And so inherently they're a trained surgeon. That being said, they're also a really wonderful medical doctor. And so I find, depending on the level of TBI, they can be incredibly helpful. So some people with, let's say, a severe traumatic brain injury where they have a cranial nerve palsy and one eye just can't point in one direction or the other mechanically anymore, you're going to need a surgeon to help stabilize that or fix that. So I think neuro-optometry is really helpful for the non-surgical visual aspects. Sometimes patients need both. And I see a lot of patients where they see neuro-ophthalmology first. They get the medical exam and kind of the surgical opinion, then they see me second, or vice versa. I work alongside them all the time. I think inherently, if you're looking for vision therapy, ophthalmology doesn't do vision therapy, and they're not trained to do vision therapy. A lot of them don't necessarily understand it. There was a position paper that came out last July by the American Society of Pediatric Ophthalmology saying that they do now recognize that vision therapy is an adequate treatment for convergence insufficiency, which is huge because ophthalmology has not been very big on vision therapy for a long time. But sometimes I think, that's where we hit a little bit of a barrier, is knowing which eye care provider you're supposed to see.
Okay, and optometrists, just as a matter of course, are more trained to deal with the problems with visual difficulties in terms of TBI, as opposed to neuro-ophthalmologists who are going to be dealing with surgery. Is that basically a fair statement?
Honestly, it depends person to person. And I don't think I could say that their whole field or our whole field is better. I think at the end of the day, if you've seen one brain injury, you've seen one brain injury. So even within my own field, there are going to be some people that are better at it than others. And it all just depends on how many people you've seen.
Right. And then just the second question, if a person has a very severe TBI, do you think the primary care doc, as a matter of course, should say, look, you should get an ophthalmology examiner or an exam by either an ophthalmologist or an optometrist?
Yes, absolutely. Especially if they're having visual symptoms persistent beyond 4 weeks. Anytime, and I give a lot of lectures to pediatricians and primary care physicians, and I always say, if there's an eyeball symptom, meaning like, hey, I have a bunch of flashes and floaters in my left eye, you should go see an eyeball doctor, and sooner rather than later for those kind of eyeball symptoms.
Got it. Thank you so much, Doctor.
Mm-hmm. Kara, would you like to ask your question? There you go.
Hi, my name is Kara. I work with Catherine at Pink. And I just had a question. Thank you so much for pursuing this initiative. I think it's definitely prior, to more recently a neglected area. Have you seen increased awareness and integration of vision diagnosis and therapy in concussion clinics, sports, and schools? I've seen for students during rehabilitation, vision deficits can be misdiagnosed as a concentration problem. And the neuro-optometrist, Dr. Vincent Vici, regularly evaluated, diagnosed, restarted my vision therapy, and prescribed proper glasses to remediate this problem, and was just of tremendous help while I was in grad school.
Yeah, so I think we're definitely doing a much better job of awareness of needing to make sure that there isn't a vision problem actually causing the symptoms. So in general, whether it's post-head injury or developmental, we do know that ocular motor dysfunction can sometimes masquerade as inattention, particularly with cognitive tasks because they're visually demanding. And so a lot of kids can maybe be diagnosed with ADHD and ADD, but really they have an ocular motor problem, or they have both. You can have both as well. And so I think it is imperative to make sure that you don't have something else that's also contributing to those symptoms. And as I had mentioned, a lot of ocular motor problems go with symptoms like inattention, fatigue, brain fog, not being able to be in a crowded environment. And a lot of people will attest that to other type of psychiatric disorders sometimes, or cognitive disorders.
Exactly. Okay, thank you.
And I think the injury alone increases for some people anxiety and isolation, and then you walk into a large either party or a shop or movie. Well, we used to go to movie theaters. We used to go in, and then you have this additional issue with your eyes, which then increase the anxiety. It can be exponential, where you're, isolated even from going to places that you want to go into.
Yeah. Well, and the social isolation, even just being light sensitive can make you socially isolated, let alone also knowing that when I go to this place, I'm going to get very fatigued, or it's going to give me a migraine, or it's going to make me dizzy and nauseous. So I don't want to go. And then you don't see people. And then I think we kind of call it just like that cyclone. You're just going to go down this psychiatric cyclone where you're not going to necessarily feel any better, because to feel physically better, you have to socially isolate yourself. And when you're socially isolated, then psychiatrically, you're not feeling better. And then it just kind of ebbs and flows. And the longer that it goes untreated, the harder it is, I think, for patients in general, especially if they don't have a good support network, like people who live at home by themselves, as we learned during COVID. I think if anything, people are at least more aware of how awful social isolation is. And I think people are a little bit nicer to people now about it.
Well, I definitely saw that in the first couple of weeks of the pandemic. Through our 14 Facebook groups, we have about 8,000 people across the world. And there were people commenting saying, yeah, people are now asking me, the person with, the person with the brain injury that has been isolating, how do you isolate? Like, how do you do this? So there was a sense of, yeah, like, welcome to my world. It's not so fun to be home every day. Yeah. So, well, I really appreciate you coming on. One last question with perception, depth perception and color perception. Do you see those issues with TBI?
Depth perception, absolutely. If the eyes aren't pointed perfectly and teaming together perfectly, you can feel like your depth perception is off. Color vision is going to be color vision is an aspect of your afferent visual pathway, or your optic nerve, which is kind of more protected in the brain. So I find color vision isn't normally impacted in concussion per se, but it definitely can be impacted with patients who've had damage along that pathway from more moderate or severe TBI.
And one last warning I just want to put out there: if you are around somebody that has a possible concussive event, having them get into a car is really not a great idea. And that's something that the military screens for, and they used to, after a TBI, you had to actually take a road test again with an instructor to be able to go back there. So that's one of the things when I get calls from people that, don't go out and explore the world by car for the first 2 or 3 days after a possible event or a diagnosed event, because your vision and eyes may be off. And at least even driving in a car as a passenger with headlights, you can be symptomatic. So any other last comments that you'd like to throw? I know there's more questions, but we're at the top of the hour, and I do know people have to go. We'll be back next week. We'll send out an email. We'll have some great Dr. Ziegler. Do you want to just do a quick promo for him next week? Jacqueline?
Oh, sorry. For Dr. Zazzler.
Yeah.
So I as I mentioned earlier, I lived and kind of grew up optometrically in Berkeley, and I had this wonderful opportunity to work with Dr. Zazzler, who lives in Richmond, Virginia, and I dropped everything and moved across the country to be able to work alongside him because he is such a wonderful provider. He is a physical medicine and rehabilitation physiatrist doctor who also is brain injury certified. He is incredibly compassionate for his patients, and I just learned something new about brain injury from him every single day. So you guys are lucky to have him.
He'll be on next week. So thank you so much. And I appreciate everybody spending the time. I'll put this up as on our YouTube channel. This is our 29th episode. We have 28 episodes already up on YouTube. It's all free. You can forward it to other people. If you want to make a donation to Pink Concussions, welcome it. And we want to thank IBIA and NABIS for helping us and sponsoring us on their platform. Any final words?
Thank you for coming back. We missed you.
Oh, I'm glad to be back. Dr. Theis, anything else you'd like to say to the group?
I will say one thing, because it's the most common question I get later after podcasts and things like this is, how do I find a neuro-optometrist? So NORA, the Neuro-Optometric Rehabilitation Association, has a website for find a provider, and you can find someone near you. I know I do telemedicine, so some of them might do telemedicine as well. So if they seem like they're kind of far away, you can reach out to their office and see if they'll still be able to treat you.
And they also have a great concussion newsletter that every week I get in the mail, and it summarizes all of the research. So that's NORA. So thank you so much. Thank you for everybody for joining us today. And we'll see you all next week, 2:00 Thursday, Eastern Standard Time. Thanks again, Dr. Theis. Bye-bye.
Thank you so much.
Bye.
Bye-bye.